I bring greetings from the Indigenous Health Advisory Committee of the Royal College as we discuss something meaningful to share in our message. We went back to the role that we have in looking at and exploring bias and how that can influence the creation of discrimination and racism within care pathways. We believe that bias, particularly unconscious bias, can have a profound effect on Indigenous peoples, especially in this area of prescription drug use and abuse. I thank the Canadian Medical Association for allowing us to have this discussion, which I don't think we could have had even 5 years ago. Bias is an active area of research, both in Canada and internationally. And you can see it in the literature in different names, including things like the hidden curriculum and diagnostic momentum. The link between bias, discrimination, and racism in Canada is less elucidated than it is in the United States and internationally, mainly because we don't collect demographic data on many of our patients. This is unique among Canada when you look at the United States and many other countries in the world. We therefore cannot mine the links between ethnicity and outcomes in healthcare. Despite this, there's considerable anecdotal and literature-based evidence that bias does have an effect on patient care. And there's been many of these studies that have been published in the past few years. I don't suggest that healthcare professionals mean to harm Indigenous patients, and I'll make that very, very clear. This is a sensitive subject to discuss. I do suggest that there are narratives we learn about Indigenous patients, and that shapes the way we approach them. Well-meaning clinicians can unintentionally harm patients when not understanding these biases. I'm going to put up a slide here, and I'd like you guys just to walk through an exercise real quick. Just read through this paragraph. I'm going to give you 3 seconds, and I want you to count the Fs. So I'll give you 3 seconds, 1, 2, 3. Now, I'd like you to be honest with yourself about how many Fs you saw. So how many people in the audience saw 3 Fs? Can you raise your hands? How many people saw 4 Fs? Can you raise your hands? How many people saw more than 4 Fs? Yeah, so that's about average, half and half. How many Fs were actually there? So in reality, there's 6. Now, if you only saw 3 or less, you're actually part of a very large majority. There's 2 main reasons why people don't see the Fs in this exercise. The first is we're taught in our reading to focus on content whenever we read a paragraph, especially when we have time limitation. So when you read through the paragraph, you're looking and skipping the ofs, the thus, and the as, focusing on the larger words, the things that you expect are going to give you the content. The second reason is that when we read a paragraph, we usually read auditorily in our heads. So the sounds in scientific and files sound very different than the sounds in of. Now, it's interesting that there's 2 groups that this always fails to trick. The first one is those who do not have English as their primary language, so I expect our Francophone colleagues were not tricked by this. Secondly is people who don't graduate beyond grade 6 in the public school system. Now I'm going to have you read 3 triangles here, and I'll just have you read top through the bottom and the top again. So just first, second, and third triangle. What I expect you read was Paris in the spring, once in a lifetime, and bird in the hand. But is that what they actually said? The triangles actually say Paris in the spring, once in a lifetime, and bird in the hand. So even when I've told you that there's a trick, even when I immediately told you that there was something there that you didn't see, you still couldn't see it. So here's the big question, is does this affect patient care? So the system is actually designed to promote bias. We're taught to categorize and assign in our care pathways. In fact, we take great pride in our ability to make clinical decisions based on incomplete information. This, of course, is our initial working diagnosis that we initiate care, and there's very practical reasons why we're trained this way. Limited information is sometimes all that you have to work on. There's patient considerations and systems considerations that push us in this direction. All of these things collect into a type of profiling that we do on patients. Now, when you look at studies, and there's multiple studies that have been done since the 1980s, we find that the bias that we develop against patients who walk into our clinics, for better or worse, happens in as little as 10 to 18 seconds. So instead of viewing ourselves as biased, we often create creative justifications on why we make decisions these ways. And bias is only harmful when we don't question the bias that we have. When we initially peg a patient as being one way or another within those 18 seconds and not corroborate those decisions based on new information like history, physical exam, lab work, as well as other investigations. In the investigation of Brian Sinclair, a Cree patient that presented to a Winnipeg emergency room, you can read in the report and investigation that was done that over and over again, healthcare professionals labeled him with the bias that they layered over what his medical condition presented as, that he was drunk and homeless. No one in any of the healthcare professional stream decided to go and actually ask him why he was there. They did not do a physical exam. He never had vitals taken, even though he was in that emergency room for over 30 hours before dying from treatable urosepsis. So what are the biases that Brian Sinclair had placed upon him? If you've worked with First Nation, Métis, and Inuit patients, I expect that you've probably come across these. The most relevant one to the discussion we're having today is drunks and addicts. So what does this have to do with addictions? So in Saskatchewan, there's 70 First Nations. We're going to focus on 3 in the southeastern part of the province. These are the Key, the Kisakus, and the Cody First Nations. It's important to understand a bit of the local history. So following the Riel Rebellion, a large group of these inhabitants were transported from northern Manitoba to this area. As part of the assimilation policies of the mid-20th century, children were sent to St. Philip's Residential School, which was very near this area. This was one of the 2 worst residential schools in all of Canada when it came to physical, mental, and sexual abuse. St. Philip's operated until the mid-90s. It was actually closed in 93 or 94. So anyone born in 1985 or earlier likely spent some time at this residential school as part of their education. Residents for years haven't dealt with residential school trauma, intergenerational trauma, propagated sexual abuse, broken families, and the effects of purposeful loss of culture. This is an area that has a very young population, a very high alcohol abuse rate, and high prescription drug use. Patients have long complained about high levels of discrimination in the area when accessing health care. So responding to a perceived issue of prescription drug use, the health region that was close by this area, along with Health Canada, decided that they were going to create a methadone clinic in 2009. The community was not consulted at any point during this process. Over a short period of time, existing alcohol and prescription drug use was slowly transferred over to methadone. For many who had never used pills before, the increased availability of methadone drove a demand and expanded use of prescription drugs into younger and younger ages, not just the 40 to 60-year-olds who had directly interfaced with the St. Philip's Residential School. At its height, there were 157 patients who were on the methadone panel from this small area. Now remember, there's only 2,000 people on these 3 reserves. 52% of the population are children. So we're really just talking about a catchment of 1,000 adults. If you put this into perspective, there are only 2,200 patients in a methadone maintenance treatment program in all of Saskatchewan. So within this small geographical area and this 1,000 people, 7% of the entire demand of Saskatchewan was driven. The number of patients being seen on these 3 reserves was half of the total number of patients that were seen in Saskatoon, a city with 33 times the population size. The clinic was grossly underfunded, with less than 1/10 of the funding in a similar program in Saskatoon. There was no counseling, there was no pre-screening, and the doctor proudly noted multiple times that there was a very low threshold for placing patients on methadone maintenance therapy. There's a story that was shared with me by one of the chiefs of the reserves and said that he was going into the pharmacy to get his newly prescribed heart medication. He was placed into a line on the far side of the room. After sitting for 20 minutes, he eventually got to the front of the line and was asked by the dispenser how much methadone he was on. He told them, "I'm not here for methadone, I'm here for my heart medication," to which the dispenser replied, "I know that, but how much methadone are you on?" This has happened to many, many patients who have physical features that identify themselves as First Nations. I'll also note that the child apprehension rate on these reserves is 4 times the Saskatchewan average, and this is linked to some of the policies that surround methadone treatment. Visiting with us is Senator Ted Cusance from the Assembly of First Nations. In the past 11 days, he's been at 10 funerals, all linked to prescription drug use and abuse. Now, some consider this to be a unique case, but in a study by Lakehead University of 10 northern Aboriginal fly-in communities in Northern Ontario, more than a third of these communities had 100% prescription drug use. Why is the situation repeating itself over and over again across Canada when it comes to Aboriginal peoples? Let me suggest that there may be some narratives we believe about patients that contribute to health outcomes in this matter. For many reasons, our bias can influence our practice. It is in a soon-to-be-published study on inflammatory arthritis outside of Calgary, they found that the incidence of opioid prescribing is 13 times higher for inflammatory arthritis when you compare Aboriginal and non-Aboriginal patients. This is the same type of data we actually find among ethnic groups in the United States and internationally. And there's a lot of very, very well-established data internationally that shows this. Our first impressions, our bias, often can drive our patient care. Instead of the history, physical exam, lab work, and other investigations we should depend upon. Like what was done to Brian Sinclair, we may mindlessly make decisions that have considerable effect on patients. In patient's own words, I've had such horrible experiences with doctors in the past. He looks at my name on the chart. He says, "Oh, Acus." He says he used to live down by Sakamay and he used to see a lot of these people, those Acuses, and they were all drug addicts. I was taken aback, so I tried not to be ticked because I was. This is actually one of my old professors. She's a PhD in health disparities. From the second patient. When I was pregnant, they'd ask me if my baby was going to have fetal alcohol syndrome. They always say, "How many kids do you have? How many more are you going to have? Are you going to get your tubes tied after?" They put that on me because I'm First Nations. This bias can also feed the uncomfortable environments many healthcare practitioners encounter when working with Aboriginal patients, as well as drive both patient and practitioner behaviors. Patients can often have decreased patient compliance when entering into hostile situations where they feel that they've been biased. They can delay presentation. There can be an increased risk of conflict and aggression during these patient interactions. Misdiagnosis eventually leading to increased morbidity and mortality are common. While from practitioners' points of view, there's often increased frustration with these patients. Simple situations become more complex when patients don't share clear histories. Stress and discomfort can happen. There can be poor morale when treating patients from Indigenous communities. There's increased complaints and potential for boundary violations, as well as eventual litigation and burnout. It's for these reasons that the Royal College has been focused on exploring the role of bias, discrimination, and racism in care pathways within health. The Royal College has published 2 landmark documents on this, along with a framework developed by the Indigenous Health Advisory Committee and the Office of Health Policy and Communications at the Royal College. This identifies how these issues can be dealt with by developing specific competencies using the CAN-MEDS framework. A couple of final thoughts. I have seen the approach to drug addiction shift from sobriety to harm reduction to opioid substitution. An addict is only successful at treatment if they stay in their program. They don't want to deal with the problems of colonialism in residential schools, so they blame us. The Truth and Reconciliation Commission reconfirmed the findings of the Royal Commission on Aboriginal Peoples. We have to confront the role that our healthcare system has in keeping us sick. We have to confront what we believe about Indigenous peoples. So what can we do? As physicians, we need to recognize that we can educate ourselves to see this hidden world. It is my strong belief that the widening health disparities we see among Aboriginal peoples and the heartbreaking stories of tragedy can only be narrowed if we see and reject the unconscious narratives we believe about Aboriginal peoples. We know that there is a gap in care between Aboriginal and non-Aboriginal patients. We know that Aboriginal patients encounter significant harm, often even death, due to these gaps. What do we believe as physicians that makes us so disempowered? What do we have to believe to actually change things? In addition to implementing the best practices shared here today, recognizing and exploring the role of bias in prescription drug use, abuse, and treatment is a necessary component in tackling the crisis among Aboriginal peoples. By instituting the steps outlined in the Truth and Reconciliation Commission's calls to action, we can reject harmful narratives and make enormous impacts towards patient care. Thank you.